Make sure we're streaming. Good morning. Good morning. I'm Delegate Rodney Willett, serving as your chair this year for HHS. It's an absolute honor to be doing that and to be with you this morning. I'll have a few more things to say in a second, but we're going to jump right into action and we will call the roll. Excellent. I think we may get a few more people. We've got a quorum. I think we'll get a few more people coming in. But no. First and foremost, I really want to thank everyone for being here. I'm just we are so blessed to have such an impressive committee. A lot of returning folks and a few new folks. And again, I just really appreciate everyone diving into what's arguably going to be one of the most important years ever for healthcare. The challenges we are facing in terms of cuts coming from the federal government. We had challenges before that in terms of affordability for health care, access to health care, and those things have only gotten worse with what's happened. So we're going to have a full plate with this the committee, but this is a great group, and we're going to have an excellent set of subcommittees to go along with that, with more to come on that later. But I thought what we'd start do, because we do have a few new faces here and obviously a lot of familiar faces, but I think we'll just go down the dais here and introduce ourselves. So I think everyone knows me as Rodney Willett from 58th District in Henrico. I have my vice chair, Kathy Tran, to my right. And if we haven't had a mind meld already, you got to have an icebreaker. This is the first meeting. Got to let people work into this. And Kathy and I, Chair Chan and I, had the exact same thought, which is kind of scary, but we thought each member should tell you where you're from and then say one healthy thing that you think we all should do. One healthy thing we all should do. This is the Health Committee. So I'm going to start off and say I am a runner. I don't expect everybody to run, but move as much as you can. Movement is key. Even if it's getting from one building to the next, if you can move at least a little bit during the day, that's going to make you healthier. So Vice Chair Tran.
Good morning. All right, we'll start over. Good morning, I'm Kathy Tran. I represent the 18th House District, which is parts of Southeast Fairfax County. I am thrilled to be on this committee again and to be working with our new chair, Delegate Willett. I think it's going to be a really great session as we continue to expand affordable health care for all Virginians. I have my own personal water challenge this session, and I'm trying to drink as much water as possible and stay hydrated.
Good morning. I'm Delegate Sia Price. I represent the 85th District, which is parts of Newport News, and I would like for you all to stop asking to hug me. This building is disgusting. Thank you.
Good morning. Am I on? Yes. Good morning. I'm Cliff Hayes. I represent the 91st District, which is the northern part of Chesapeake and a portion of Suffolk. And my recommendation to all is that we drink more water.
Good morning. I'm Charnel Herring. I am the 4th House District, which is West Alexandria City and parts of Fairfax County, the Bailey's Crossroads area. And my healthy suggestion is yoga. It's good for handling grief. It's good for handling stress here. And I wish everyone would learn the art of yoga.
Good morning. I am Joshua Cole, representing Virginia's 65th House District, the city of Fredericksburg, Stafford County, and Spotsylvania County. And my healthy suggestion is be like me and walk everywhere. I'm not going to tell you to take the steps, but walk everywhere.
Good morning. I'm Deborah Gardner, and I represent the 76th District, which is parts of Chesterfield. And my healthy tip is to just breathe.
Good morning, JJ Singh, 26th District, Loudoun County. My suggestion is to listen to everybody else up here because I have nothing to offer. Thank you.
Laura Jane Cohen, representing HD 15, and my tip would be that you can replace water with Diet Coke and still keep going. So.
Good morning. I'm Dr. Mark Downey, a pediatrician for the last 25 years from HD 69 in York County. I'm not a runner. I'm a swimmer, so it's kind of a win-win. You get to swim and get in water at the same time.
Good morning. I'm Mitchell Cornett, the 46th District, Olive Grayson, Smith, and Wythe counties, and a portion of Pulaski County in Southwest Virginia. And I recommend visiting Southwest Virginia and taking advantage of some of the outdoor opportunities that we have.
My name is Tim Griffin. I'm House District 53 from Bedford, and I'm honored to be here. I found the chairman, easy to work with in the past. So I always eat garlic, turmeric, elderberry, vitamin C. So make sure you're eating all that stuff all the session. Thank you.
I'm Delegate Waxman. I'm a pharmacist, so I certainly enjoy this committee. Must apologize. My voice has been cracking the last couple of days. I represent Sussex, Greensville, Southampton, City of Emporia, Brunswick County, portions of Dinwiddie, and also Isle of Wight, definitely a medically underserved area. My recommendation is to read your labels, and I'd also like to say that I'm glad there's a doctor in the house again. Thank you.
Good morning. I'm Delegate Philip Scott, represent the 63rd District, Spotsylvania, and Orange, parts of each county. Something that I do that's healthy is I watch what I eat. I watch everything that goes in my mouth, and I enjoy it thoroughly. But on a serious note, no, I do take supplements. I like to use essential oils to help my body deal with whatever else may be happening.
Delegate Mike Cherry, I represent the 74th House District, which comprises all of the city of Colonial Heights and the lower tier of Chesterfield County. I love to mountain bike, but I think the healthiest thing that I try to engage in as often as possible is the intersection of sport, health, and bourbon, which is golf.
I'm Wendell Walker, 52nd District. I'm not a bourbon drinker, but it's nice to drink clean Richmond water. I thanked the mayor the other day. So I guess my advice at this stage of my life is keep moving, don't stop.
Good morning, Keith Hodges from the 68th District. Pardon my voice. But 68th District is Virginia's Middle Peninsula. I am a practicing pharmacist, have been on this committee since 2012. And although as a pharmacist, we talk about our medications, we often refer folks to Dr. Daniel. That's Dr. Jack Daniel. But depends on the patient. But anyway, as far as staying healthy, take your medications properly. Non-adherence contributes to 30 to 60% of hospital admissions a year. And poor adherence, is a major factor in that. So talk to your pharmacist and take your medications properly.
Good morning, Sam Rasool from Roanoke, and being from the Star City and also being Arab American, we're big huggers. So any of the hugs you're not giving to Sia, you could bring them down to me, I guess.
Good morning. I'm Mark Sickles from the 17th District until 11:59 Friday night. Been 22 years since I've been on this committee, but I want to tell everybody, brag a little bit. I got 9,200 steps yesterday. For me, that's a lot. And my advice is, no matter what the weather is, take the tunnel because you can get a lot of steps in.
Thank you. Well, that was exceptionally enlightening and helpful. I think we learned a lot. No, I appreciate that. And also, we have an ACE staff here, so I'd love for the staff to just introduce themselves, some familiar, but also some new faces here. So maybe we'll start. Chandler, why don't you kick us off?
Hi, everyone. I'm Chandler Brooks. I am legislative counsel. I work with DLS. I'm here to serve as counsel to the committee, counsel to each of you individually, as you're shepherding bills through our legislative process. I'm here to help. I'm glad to be back. This is my 4th session with the committee. Would you like a healthy tip? My healthy tip is talk to yourself positively. There's a lot of body image and things like that. I think it's important to talk to yourself in a kind voice. And that's my tip.
Hi, good morning, everyone. My name is Madison Richardson. I am also DLS staff. I also am the program coordinator for the Commission on Women's Health. So I also look forward to working with all of you, and I'm also here to help. I guess my healthy tip as well is to just, find healthy balance. Doing yoga, I feel, really helps me to calm my mind and my body. So that's my tip for the day.
Hi, I'm Susan King, and this is my third session in this committee. And I'm the room clerk, and I assist Jane. And I'm all into what Chandler said. Talk to yourself positively.
Right. Hi, I'm Noah Ash. I'm a house page, and I'm here to just assist on things in the committee. And so.
My name is Jane Ash. I am the clerk for this session's Health and Human Services Committee, and it's my first year, so be patient with me, please. And my healthy tip would be protect your sleep. Get a good night's sleep.
All great advice, and it's great to have a great team here. We're so blessed. I do need to bring things back to sort of where we started in terms of introductions. I am filling very big shoes and taking on this role, and it is a real mixed blessing for me to have Chairman Sickles moving on to his new position with the Spanberg administration. He has absolutely been a mentor to me from day one, and I have just been in awe of what he's been able to do in his role, multiple roles, but certainly his role here on HHS. And I just want to thank him for all he has done. Okay. Virginia's a healthier place because of Mark Sickles, and he really has led our efforts now for years in the minority and in the majority, and in this role as chair, and of course also in his role on appropriations. We really appreciate that. I could talk for hours about what Mark has done, and certainly the personal benefit to me from that and what I've learned. But I'll tell you one thing, and I'm going to take this as a challenge, is that the chairman has never been afraid to ask the tough questions. And I really take that as a challenge to me, because I need to ask tougher questions sometimes. I think this committee needs to ask tougher questions sometimes. But also to do it in a very collaborative way. Ask the tough question, but also let the person answer and let them provide the information that actually may help us make better decisions. And he's done that just exceptionally well. So that's my challenge, is to take that lesson. And as we go into our deliberations, because there'll be a lot of deliberations here. But again, Mark, I just can't thank you enough. So, thank you. Okay, thank you. Okay. Just a little housekeeping, then we've got some excellent presentations I want to get right to. Probably most significantly, as I think everyone in this room knows, we have an excellent group of subcommittees, and we were going to keep the same subcommittees. We just got our members for the committee yesterday, so we need to get the subcommittee assignments done, and the vice chair and I'll be quickly working on that, and you'll see that posted, and then we'll go right, of course, into our subcommittee meetings. As you know, there are a lot of bills to get through, and so we'll go really from 0 to 100 pretty fast here to get through the bills we have to get through and to stay on schedule with what's going to be a super busy time for all of us. But I really think of this as a collective effort, as a collaborative effort. I've a lot of familiar faces in this room. I'm sure there are folks online as well who we've worked with for years here, and we depend on you. There's a dialogue here, and we need those inputs as we make our decisions. I am by no means a healthcare expert. I'm happy to have a doctor sitting in front of me, sitting on this committee, but I think even Delegate Downey would agree, none of us can be expert in everything here. This is a very complex area, and we need your help, so I really appreciate that. I did want to give a shout out to one of our partners in doing this, Don Harris. I think a lot of you know That was part of the deal. I said, I'm not going to take over this chairmanship. Kathy said the same thing, unless Don Harris is coming with the deal. So, God. And probably the happiest person in Virginia was my chief of staff, Callie Lynch, when she found out that Don was going to be part of this team, because she was concerned about this. This is a big committee. It's a lot to do. But Callie will be helping us as well. But again, we're so thrilled to have Don back. So with that, we've got a couple of presentations today, and we'll just jump right into that. This is just to get us as much up to speed as we can. There is so much in play right now. At the national level, which of course is affecting the state level, and nothing, and no more important impact than what's happening with our Medicaid system. So we've got Jeff Lenardi here today to give us an update on where things are with that transition, and the transition, what's happening with that, and really appreciate that. And we'll get a presentation, and I think we'll get a few questions in there too. Hey, Jeff.
Good morning, Mr. Chairman. Is this on? We're good. Good morning, Mr. Chairman, members of the committee. It's good to see many of you again. Chairman Sickles, I don't know if I can handle two chairs on the same dais. And I would also encourage everyone to, I'm sorry. I would encourage everyone to take Chairman Willett up on his advice to ask hard questions tomorrow. So, yeah, we were asked to come and talk specifically about mostly the eligibility impacts in H.R. 1, so I'll focus on them. I'll start big picture on sort of a quick rundown on everything that's in there, but then dive in to the eligibility. I also want to mention a couple folks who were here. If I do get hard questions, they'll be called up. Miriam Siddiqui from our team, she is one of our internal leads, sort of coordinating all the many policy operational aspects of this implementation. And then from our DSS partners, who you all know we have to work very closely with, and we're grateful that we're able to do that, Carl Ayers and Nikki Cox, two of the key staff there. And so it certainly takes a village, and looking forward to continue that work on the executive branch side and continue this discussion with you all through session. Oh, wrong button. There we go. So as I mentioned, H.R. 1 certainly has a lot in it for Medicaid, also for SNAP, for Virginia's insurance marketplace, which you're going to hear about after me, but also others. I think the one thing I want to highlight at the outset is that the timeline, particularly for Medicaid eligibility changes, is very, very tight. The ones we're going to focus on today, which is starting to redetermine eligibility every 6 months for our Medicaid expansion group, as well as operationalizing work and community engagement requirements, we have to have them up and running before the end of this year. And so that's a heavy operational lift, and so we have been hitting the ground running for months already, and we'll continue to do so we can get that up and running. The other things that I will just flag quickly that have gotten a lot of attention, obviously changes to what the federal government calls state-directed payments. Here in Virginia, we call them supplemental payments. That are going to impact some of the Medicaid revenues to our hospitals. That's a big change coming in H.R. 1, maybe more discussion about that upstairs later during session. Cost sharing for Medicaid expansion individuals when they go and see certain providers. And there's also some program integrity changes, one in particular that I'll highlight a bit later that I think is important for everyone to have on their radar. One thing I do want to share is that the messaging from CMS has been exceptionally clear, which is that particularly work and community engagement requirements and every state being operationally ready by the deadline in the law is their number one priority. There was the national conference for Medicaid directors and staff is in November every year, and I think 2/3 of the sessions were on that particular issue, and we were grateful for that because while formal guidance isn't out, CMS is sharing as much as they're able to so that we can start to design systems and processes and policies, but that messaging has been extremely clear. So this is a snapshot. Those of you who are returning have probably seen this before from us. This is essentially everything in H.R. 1 that touches Medicaid. Obviously today we're going to focus on the ones with a star next to them. Those are the eligibility components. And again, as you'll notice in the timeline, they're some of the earliest, and then particularly with work community engagement, some of the most operationally complex. So I'm going to just spend a couple slides on on some of the other eligibility changes in HR 1, and then get into the details that we were asked to talk about. This first one, it changes a definition of which types of immigration statuses are eligible for full benefit Medicaid. So you see there's an effective date here, October 1st of this year. CMS has been sharing files with states to validate that the individuals they've identified that are subject to this change are enrolled in our state, and we're working back and forth with CMS on. But again, effective October 1st, those individuals will no longer be eligible for full benefit Medicaid. They would be eligible for emergency Medicaid services if they have a need for those services. Next, they call it reducing duplicate enrollment. You also may hear this referred to as concurrent enrollment. This is, interestingly enough, this is a process that's been going on in states and Medicaid for years, but HR 1 changes the way we do it and also provides additional data to states to implement that. So what this is individuals, particularly in border areas, so for us it's Northern Virginia, it's the Tennessee border, the West Virginia border, North Carolina, they may move back and forth depending on how the community is there, that they live, and so they can end up enrolled in 2 states at the same time in Medicaid. And so we look at this more as a cleanup than anything else. So if an individual is enrolled in Medicaid in Virginia and Tennessee, we want that person enrolled in whatever state they currently live in. Right now, the process is we get some data in from the federal government, and sort of for lack of a better term, the burden's on the state. We assess those individuals, we reach out, we try to determine where they live, and if we can definitively determine that they live in a different state and not in Virginia, then they're disenrolled from coverage here in Virginia. What HR 1 does is it flips that operational process. So what we're going to be required to do is when we get those individuals who we have information are enrolled in Virginia and also in another state, they will get a notice from us. They'll get communication. They'll have about 10 days to respond and tell us where they do live, where their current residence is. And then if it's not in Virginia, then they'll be disenrolled at that point. If it is in Virginia, then they'll stay enrolled in Medicaid. So it's really a process change to try to make sure that individuals are enrolled where they do actually live. So the ones on this slide are a little more nuanced, not as much public attention. The first one is the one that has an impact on some Medicaid members. So currently, if you apply and are eligible for Medicaid, you can get retroactive coverage from 3 months prior to when you applied. Depending on the type of covered group that you fall in, that's being shortened to 1 month if you're in Medicaid expansion. And then up to 2 months for children and mothers who were in what we call our CHIP program. The second one is another one we already do, which is essentially having an efficient process to ensure that once someone passes away, we take that action to close out their case in Medicaid. We have a pretty robust process here in Virginia to do that. There's actually been a lot of work done the last 3 or 4 years on that process by our eligibility team. And this essentially provides an additional data source. Currently, we use the VDH, Office of Vital Statistics data, and this will provide an additional federal data source from Social Security Administration. The last one on this page is one of the program integrity ones I want to highlight. As you can see, the effective date is not until October 1st, 2029. So not a this session financial discussion, but it will be a significant discussion for the state in years to come. So I know there's been a lot of talk about the SNAP error rate after HR 1 was passed. There was a significant potential state financial liability, and obviously DSS has been laser focused on that this fall and continues to be. This is analogous to that on the Medicaid side. So there's an every 3-year process in Medicaid where the federal government does what's called a payment error rate measurement PERM process. We just finished ours, so ours is not up again for another 3 years. But when our next cycle comes up, if that error rate exceeds the threshold in HR 1, then we will have similar federal financial participation, or essentially, we'll lose federal funding to the extent that our error rate is above the designation. So don't lose sight of that fact as you go through the next several General Assembly sessions. Okay, so the 2 major changes we're going to talk about are redetermination every 6 months, as well as work and community engagement. So eligibility redetermination every 6 months, when we think about this conceptually and operationally, this is sort of the base. First, we've got to implement the changes to do this. The good news is, while it is more work, obviously, on the staff that do this, and it's a new requirement for members they need to be aware of, it's the same process we already do. We already do renewals annually for every Medicaid member. This is for a subset, the Medicaid expansion population. There's about 500,000 of them currently that will be subject to renewal every 6 months. And so as we flag here, we'll need funding and the authority to implement those changes. Those are, our proposals are in the governor's introduced budget. And we're already working on planning out and scheduling the systems changes that are going to be needed to do that. And then one proposal in the governor's introduced budget that I'll flag is for a Medicaid expansion case that doesn't touch other benefit programs. It doesn't touch SNAP, doesn't touch TANF. The proposal is to enable Cover Virginia, which is Medicaid's central call center and eligibility unit, to actually do that renewal process for that individual. So take that, don't put those additional cases on the locals since they don't have to touch them for another benefit program. So again, I think we'll get to sort of our operational philosophy in a few slides, but I think in sum, we want to invest in a way that minimizes burden on those who are involved, both the members and the staff who are determining eligibility. All right, so for work and community engagement requirements, those same Medicaid expansion individuals, but a subset of them will be subject to work and community engagement because there's a bunch of exceptions that I'll go over in a couple of slides. And so that will happen at initial application and then during that every 6-month renewal. So every state has to do this, and so as our team has sketched out, they've put together a lot of these guiding principles. I think the ones I'll flag here is sort of middle at the top is number one, it needs to be member-centric, and look at this from the sort of the member journey. How do they engage with our eligibility system? How do we make it easy for them to understand what the requirements are? Provide any documentation that needs to be provided so that they can maintain coverage based on the circumstances they have that meet those requirements. We also want to make low administrative burden. For members, obviously, we want to do as much electronically as humanly possible, but also for eligibility staff. As you all know, there was an eligibility report that you all directed us to do last year. The caseload for local DSS staff has grown much faster than the resources over the last really 5-6 years, going back to Medicaid expansion. And so we want to do as much as we can to not add administrative burden on the government side. And then we really want to engage all partners. We're going to talk about the communication strategy in a minute, but I think it's really, really important that we all be singing off the same sheet of music, and you all can be partners in that too, because your constituents rely on you for that information. And so certainly as we have it, we'll make sure we get information and bullet points so that when you get constituent questions, you can answer them clearly or know where to refer them to, which you all know is Will Frank. Okay, so this sketches out the details of work and community engagement. So first, the who. As you can see in the top left, this is specific to the Medicaid expansion population. So those are adults under 138% of federal poverty level. So our base children, our disabled, our elderly populations, they are categorically exempt under H.R. 1 from these requirements. And then within that Medicaid expansion population, if you look at the yellow side, these are some of the exemptions in the bill. So if you're pregnant or postpartum, if you do have special medical needs, and there's actually an additional medical frailty exemption we'll talk about in a minute. That's as the state has some options in terms of how we implement that. Disabilities, parents for children under 14, American Indians and Alaska Natives, and then also those recently released from incarceration. For those individuals who are not exempt, so sort of first thing we have to do is we take the Medicaid expansion population and we identify with our data who meets those exemptions. For those who are not exempt, what are the requirements? So that's bottom left here. 80 hours of work, community service, or participation in a work program per month. So 80 hours a month is about 20 hours a week. You can be enrolled in an educational program, but then also if you earn a certain monthly income, you're sort of deemed to be meeting that requirement. In terms of when this has to go, top of the slide says January 1st. That is the deadline when states have to be compliant with this, meaning they have to have it part of their eligibility process. However, we are required to communicate 3 months prior to an individual coming up for a renewal or applying. That means that we need to be operationally ready by mid-September. Okay, so when I say the timeline is tight, Miriam hadn't slept in a while. No, I'm just kidding. But you know, our teams are working really, really hard. And the reason I do want to flag this is we obviously have a new General Assembly. We have a new governor, and we need to be collaborative in terms of Virginia's approach. I'll talk about some of the options we have, but let's do that quickly because sort of late changes in April or towards the end of the budget cycle are going to make it really operationally difficult for us to hit that fall timeline. All right, so what this means on the left here, sort of from the member lens, and then on the right, the state lens. Again, I'm going to talk communication next, but individuals need to know they are subject to these requirements. They are new. You know, we just spent a whole slide talking about which of the 1.8 million Virginians this applies to. You know, consumers don't necessarily know or think about it in those terms, and so we really need to communicate clearly who's subject so they know. They may have to submit some new information or documentation depending on what we can and can't verify electronically based on CMS's final guidance. And then we need to connect them with resources. You know, if they are subject to these requirements and they're not currently, you know, enrolled in an education program or working or in training, we need to make sure that the resources we already do have, they know about them and are available to them. On the state side, it's very operational. So as I mentioned, it's going to require systems changes, and I'll talk about sort of our philosophy and our current plans for that. We really want to make this as automated and data-driven as possible because that reduces burden on both sides, both the consumer and the state workers, state and local workers. And then we also really need to partner. This was a lesson learned coming out of unwinding, which a lot of you lived through, where there was really a very collaborative effort from state entities, nonprofits, our MCO partners, hospital systems, where everyone was trying to communicate and carry the same message so that consumers on Medicaid understood the requirements and could comply with them. And then the other thing I'll flag is, you know, as we mentioned at the outset, there's a lot of other things in H.R. 1. There are also plenty of other implementations and programmatic changes that you all have been kind enough to direct us to do that are underway. And so it's a busy time, and we really are we're spending a lot of time making sure that we can build in these changes from a systems and operational perspective alongside those other ones. So if you take nothing else away from this briefing today, please know that communication is really the start of all of this and one of our number one priorities and one we're going to continue to talk about a lot so that we can sort of so that we can deputize everyone into the effort. During the unwinding, I think you remember there was a heavy communication campaign. We used multi-channel text messages, flyers, you know, a lot of communication through community-based organizations. This is essentially the same, but it's harder because the message is a little more nuanced. So during unwinding, it was, hey, we're doing this renewal thing again that you all are familiar with and you know what to do, and everyone, it's subject to everyone. Everyone in Medicaid has to do it. It was a pretty simple message. This message is a lot more nuanced because it's only a subset of Medicaid that's subject to the requirements. It's a lot more detailed. You know, it's not, I think I had the cover Virginia number tattooed on my head for a while during unwinding. It's a little more nuanced than that in terms of what the requirements are, where you need to call, that sort of thing. And so we really are going to be intentional and clear in our communication and really try to get that out through as many channels as possible. Next, operational strategy. So this, again, is key because of the timeline. And this is reflected in the governor's introduced budget, so we'll be talking in more detail about this, I'm sure, next week upstairs. But I think philosophically, we do have to invest in people and systems and processes in order to make this work. And so we want to do that in a way that minimizes burden on our existing local DSS infrastructure and also minimizes burden on consumers. And so from a system standpoint, the plan is to develop what we call a sort of modular system. So a system that's outside of our core VA CMS that will connect to the right data systems to verify everything we can electronically. Then it will also be able to intake documentation from the consumer if they need to submit that. And that modular system will determine, are you subject to these work requirements and do you meet them? And then VA CMS and the local worker just gets a yes or a no. And so it's less burdensome within their workflow. Rather than every local worker across the state having to learn exactly what these new requirements are, learn what documentation has to be done, and do all of those processes that many times. We have a central unit that focuses on this, can specialize in this since it's just a subset of the population, and then the answer feeds into the eligibility determination process downstream. Obviously, we also have to invest in staff. Even though we're trying to reduce the burden on locals, it will not be nothing. And so making sure they have the resources they need, both from numbers but also training. And then dedicated staff under the Medicaid umbrella to operationalize that modular system. And then I mentioned this at the outset on the every 6-month piece, but investing in our Cover Virginia call center, because if we're able to allow them to do renewals for someone who doesn't have a multi-benefit case, it's one fewer case that a local has to touch, and it's a little more streamlined for the consumer. So that's sort of strategically where we're going. A lot of nuance underneath that certainly we can kind of provide at a later date if you're interested. 2 slides quickly just to flag some of the decisions that Virginia can make and how we implement this. I think what I'll flag is these are decisions we can make pending final CMS guidance. They plan to put out that formal guidance in June. They thankfully are recognizing that June guidance for a September go-live is not operationally feasible, so they've actually been providing embargoed guidance through both directly to state Medicaid directors and then through our national association, because just like the state, they have a clearance process and it's got to get up the chain and everything has to get signed off on, but they're trying to give us as much information as they can, and we're certainly appreciative. So we can define medically frail. We do believe we're going to have some wiggle room on what we allow self-attestation for rather than documentation. And then how we check compliance. So states have the option to say, so if I apply today and I'm subject to these requirements, states are going to have the option to say, do you meet them just for the last 30 days, the last month, or do you meet them for the last 90 days? And you can do 2 months too. But so that's a state option. And then how frequently we verify, if it is every 6 months during a renewal or verification sort of in a more ongoing way. There are also hardship waivers. Again, this is one where we really are waiting for CMS guidance because these are really, really in the weeds. But individuals with certain kind of acute episodic medical issues, natural disasters, areas of the state where unemployment may be high are all potential hardship waivers that states can exercise. So I will just leave you with this very high-level timeline. There's a much more detailed one that I thought was a little too painful for this group. But again, I think the thing I'll flag is we're working, I wouldn't say we're building the plane as we fly it. I think we're designing it as we build it, if that makes sense. Because we're using every piece of information that CMS is giving us to make the best decision we can while maintaining flexibility so that when we do get that final guidance, we can implement things and go live. And I do the one thing I will say is we've also received some messaging that in year 1, that the federal government may give a little grace on some of the requirements, obviously, given the tight timeline, just in terms of enforcement. They do expect states to be operationally ready, but hopefully the guidance will give us more guardrails in terms of what that really means for year 1 versus the ongoing steady state. So thank you, Mr. Chairman. I'm happy to answer any questions at this time.
Jeff, thank you. That's a lot, and really appreciate what you're doing, your team is doing to jump into that. I know we're going to have questions, probably some hard ones, maybe some easier ones. We'll see how that goes. But let's go right to Delegate Waxman to start.
Thank you, Mr. Chair, and I really do applaud the presentation. I think all of us have been interested in this information. While this was more of a presentation from, I want to say, the mechanical aspects and what we need to be concerned about for our constituents that need these services, are there any reports on how this is going to impact providers? I live in a very rural, medically underserved area. One of the 6 hospitals that was on the closure list, that it's not really a closure list, is in my district, and a second one is just outside. Plus, I was looking at the pharmacy openings and closings for last year, and we've lost over 50 pharmacies in 1 year. I didn't know if there's another place we could go to get some information on those impacts.
Are you talking, I'm assuming you're talking broadly HR 1, not just the eligibility components?
Yes.
Yes. So we've put out some estimates through this fall. Particularly, the major change is the reduced provider supplemental payments that CMS is going to allow moving forward. The major ones we have here in Virginia are for our private acute care hospitals. And so we do have some estimates on what they look like, because they phase in over the next really 13 years. So we do have some of those. In terms of, I think what you're referring to is maybe sort of long-term, I don't call them economic impacts, but the long-term impacts on the providers. I don't have that analysis in terms of if we have projected, provider changes or network adequacy or to that extent. I think it's just something that it's hard for us to say with any sort of, definitive statement.
Thank you for the response. And Mr. Chair, as someone who lives in a very rural, high Medicaid population, when these individuals lose that eligibility, they're going to be less, physicians' visits, prescriptions, hospital stays. And I think that's really going to have a much greater, quicker impact on those providers than we may realize.
Yeah, and in terms of the impact on the actual eligibility numbers, that is something, and we can follow up. Obviously, when we put together the forecast, we had to do some of that analysis. And you start with the 500, you narrow it down to who's eligible, and then we try to use the best assumptions we can in terms of how many will comply and versus not, and so to get to that number. So we can provide that offline.
Thank you.
Great, Delegate Hodges.
Thank you, Mr. Chairman. Thank you, Jeff, for being with us. Always good to see you.
Likewise.
Appreciate your hard work. You mentioned error rates earlier, and I would assume that they're looking at things like overpayment, underpayment, compliance with, statutory requirements, regulatory requirements, administrative requirements, and so forth, and really to look at the overall efficiency of the program and to make it more efficient. How did Virginia do with that? You mentioned every 3 years. And, I would assume that we had areas we're doing well in, areas we're not doing well in. So where do we stand? And you mentioned a threshold possibly as well. So get my arms around that. And, when they come back in 3 years, are we prepared for that? Or, when...
We will be.
We will be. But, how do we fare overall?
Yeah, how do we fare?
How do we fare overall?
Yeah, we're concluding our current perm cycle. Our actual report is not out. We did very well. However, I'll say transparently in this cycle on the eligibility side, I don't have the number off the top of my head on the payment side. So the way perm works is, and not to get too far in the weeds, I apologize, but there's just sort of two parts of it. They assess how you do any errors you make on eligibility. So they sample cases and say, was it the right eligibility determination? Were they eligible? Were they not? Are they in the right aid category? Are they not? Because that drives federal reimbursement, so the feds care a lot about that. So they do an error rate for eligibility, and they do another error rate for payment. So they'll just sample claims that we pay. Make sure, was it a covered service? Was a member eligible for that service? Did you pay the right rate? That sort of thing. I don't have the payment one handy off the top of my head. I think we're positioned well. But if you look historically, those error rates can fluctuate, particularly when there are changes, because on the eligibility side, that's a hard thing for a lot of eligibility workers to all learn new requirements and then implement them really, really well. And so, I think it's just going to have to be a focus of ours over the next 2 years, because we'll come up on our cycle. They'll start that work in a couple of years, and then we'll get the report in 3 years, and that'll be the first one where we're measured against this requirement. So yeah, it's something we need to focus on. I think we're as well positioned as we can be. I can't sit here and tell you we're well under the threshold, because that's a pretty aggressive threshold. But yeah, we're going to need to be focused on it. Yeah.
Vice Chair Trent.
Thank you so much, Mr. Chair. I have 2 questions, if I may. My first question is around the impacts to our refugees and other immigrants who are here in various visa programs. Do you have an estimate of how many individuals will be affected in Virginia?
Not yet. As I mentioned, our teams are analyzing the files that we've gotten, and so that we can have a more concrete estimate of what that looks like come this fall. And as I well know, because I'll be the first to admit, I don't understand every sort of possibility in immigration status and how it lines up. It's very, very nuanced. And so when we have that information, we'll certainly provide that. And also, if you have questions about the specific statuses, we can connect you. We'll get you with our eligibility folks, and they can walk you through it.
Mr. Chair, if I may, as a follow-up, I think, many of our refugees are still connected to their refugee resettlement program, but individuals who are here in their various visa programs may just be on their own. And so I'd love to follow up on how, what that estimate looks like and how you plan to do kind of very concerted outreach so that they're aware, particularly those who don't have the extra support of like a refugee resettlement organization at this time. Mr. Chair, can I ask my second question? How, on the work eligibility requirements, what plans do you have to connect these individuals to the public workforce system so that they are on a pathway to finding employment rather than just saying, these are the new requirements? Would love to hear your thoughts.
Unsatisfying answer, but it's the truth. More to come on that. It is absolutely sort of one of the key decision points and operational processes we need to put in place. We're still at making sure like the core eligibility system is like strategically there, and that we can map out all the systems changes and also kind of work to get the resources we need to do that. But we do know that that's a critical part of this. I don't have the details yet of exactly how we're going to execute.
Mr. Chair, I would just one comment on that. I'd love to see, the two secretariats have some type of a warm handoff so that we are not setting these individuals to up for, for failure where it's harder to find jobs, and particularly, in our rural areas, I think, and even in our suburban areas, that extra kind of support so that they are meeting the requirements and are able to keep their health insurance would be really critical. Thank you.
Delegate Cohen.
Thank you, Mr. Chair, and thank you so much, Mr. Lenardi. What a nice way to start our service here on HHS. Where the state has some flexibility, like the self-attestation and hardship waivers, are those criteria that once we develop them that then could be utilized to sort of count against us then in the error rate where you talked about all the determinants of eligibility?
No, so that payment error rate, it looks at what are your policies and did you implement them accurately. So as long as our policies and whatever the state decisions are approved by CMS, then they'll measure us against those policies.
Delegate Downey.
Thank you, Mr. Chair. I had a question about the medically frail. Mm-hmm. Have you received any guidance so far? I'd be very interested in seeing what's listed on that.
That's a good question. I know our chief medical officer is working on it. We're also working with our health plans because they have a sort of a tiered case management structure, and if you meet certain clinical definitions, we may be able to use them. Miriam, have we gotten any specific guidance from CMS on that definition? Okay. So currently there's a federal definition of medically frail that I'm assuming is outside of this, obviously, that exists. And so we're basing our sort of assumptions and what data we'll use to do based off of that.
Thank you.
Chairman Sickles.
Thank you, Mr. Chairman. I have two questions. One, Jeff, you mentioned several times the need to fund our local departments of social services. Is that adequately funded in the budget now? Or are you sending a message to us that you need more money?
I might have to deflect to Carl on that. But I think DSS and DMAS are briefing money committees next week. So we can talk about that. I'm very, very familiar with exactly what's in DMAS's budget. But we'll certainly deflect to Carl if he wants to say anything on that question.
Bring him up.
Good morning, Mr. Chair. Mr. Chair from that end of it. Carl Ayers, Principal Deputy Commissioner at the Department of Social Services. What is the governor included in the budget is he did not include additional funding for local Department of Social Services staff. in regards to the Medicaid side of this. So there is funding in for the SNAP side, but it is more related to the shift of the 50-50 admin to the 25-75, not specifically for an increase in work components or things along those lines.
Okay.
Additionally, previous conversation has been about what technology funding need to be included, and there is not funding that is in the governor's introduced budget to handle the technology changes that may help us successfully reduce the error rate as well.
Thank you for that good news. You know, my second question, so the federal government is counting on people to go off of Medicaid to meet their number. I mean, they're trying to save $1 billion over some period by people not being on Medicaid in the future. So once somebody is not eligible anymore, and they get sick, or they get hit by a truck, and they end up at the hospital, who pays for that at that point?
I guess it would depend on where they're covered at that point.
Where they're covered? I mean, which hospital they go to? Or
well, no, I think in your scenario, if somebody is no longer eligible for Medicaid based on, work, so they could be covered by their employer, they could be on the marketplace, or they could be back on Medicaid, not
if they're
subject.
covered by their employer, they're not Medicaid eligible, usually. Well, maybe some low, small businesses there might be.
Or to your point, if they have a serious medical issue and now they're exempt from these requirements, they could end up back on Medicaid.
Okay. So, Mr. Chairman, I mean, somebody has to pay because we're not going to let people just die, right? So, right now we have a system where we have the lowest uninsured rate in American history right now, and we're voluntarily walking away from that. I don't expect you to answer that question, but
I will gladly not.
But somebody has to pay, unless we're going to just let people die, and we're not going to do that. So I think I know the answer to that question, so I'll just leave it hang out there. Premium payers are going to pay. It's going to be in everybody's health care premium, no matter what kind of insurance you have, I believe. Thank you, Mr. Chairman.
No. Thank you, Mr. Chairman. I think that's sort of the crux of the issue here is that we're going backwards. And Jeff, I really appreciate your presentation. There's a lot to be done here, and that timeline is absolutely intimidating. I was not aware of I guess we'll call it the September versus the January deadline on that eligibility. So I know we'll have more discussions when we change our hats and go up to appropriations. But I share a lot of the sentiment here, just concerned about the time frame, is concerned about the resources. Is CMS on the I'll call it obviously there's the staffing side, there's a system/process side. I thought at one point I heard something from CMS about some help on the system side, but is that forthcoming?
And Miriam, you're going to have to correct me if I'm wrong. I do believe that they are trying to work with vendors to develop a system states could adopt. Mm-hmm. Is that still the plan? But we're developing our own module. Yes.
Okay.
So we believe the Virginia way will work better for us.
Okay. Well, that may probably a prudent step to take. I may have fat-fingered the Q screen here. Did anyone else have a question? I may have dropped somebody unintentionally. Are we good on that? Okay, we'll see. Jeff, again, really appreciate you coming in today. Obviously, this will be an ongoing discussion. Thank you. Thank the whole team for being here. Really appreciate that. Excellent. Okay, we're gonna transition now to another absolute super important topic of the day, and that's the impact of HR 1 on the health benefit exchange, the ACA coverage. We're gonna hopefully we may get similar news here, but Kevin Patchett, I appreciate you being with us this morning, and thanks for jumping in on this.
Absolutely. I'm sorry. Okay. Give us just a second here. All right, good morning, Mr. Chair, members of the committee. It's a pleasure to be here with you this morning. My name is Kevin Patchett. I'm the director of the Virginia Health Benefit Exchange. We're a division of the State Corporation Commission. And I'm going to try to keep this fairly focused, but absolutely open to questions on a wide range of related and even unrelated topics. A little bit of background first about the Virginia Health Benefit Exchange. We were created in 2020 by legislation, as I said, as a division of the State Corporation Commission. We are funded through non-general funds that are generated through carrier assessment fees. And first and foremost, our job was to create a marketplace that was by Virginia for Virginians to transition Virginians away from using healthcare.gov to a system that we thought collectively as a Commonwealth we could do better. And the focus of all of that effort was to tailor a customer experience to Virginians that would uniquely suit the needs of Virginia as opposed to the, I think at the time, 39 states that were using healthcare.gov. In 2023, we completed that transition and began our first open enrollment period. Our marketplace, we've branded Virginia's Insurance Marketplace, and under the statute, we have a number of objectives that we are to meet through that statute and or through that marketplace and our other efforts. Really, the big one that jumps out here is to reduce the number of uninsured Virginians. And we have worked hard as a marketplace to build our network of stakeholder engagement with community partners, to fund the Navigator organizations here in Virginia that had lost a lot of federal funding over the years, to build a customer service experience that would, and a marketing plan that would reach as many Virginians across the Commonwealth as possible. One of the things that's really interesting about our marketplace is we have a tremendously diverse population of enrollees. They're geographically diverse, they're economically diverse, they're demographically diverse. And so tailoring our marketplace, our messaging, our communication, our outreach to all of these Virginians, regardless of where they live and what their situation is a critical part of our efforts to both reduce the number of uninsured Virginians, as well as to support the continuity of coverage in Virginia. So when we talk about Virginia's insurance marketplace, at the most basic level, it's an online enrollment platform that allows Virginians to shop for and enroll in qualified health insurance and qualified dental plans. We provide shopping tools that allow Virginians to compare plans, to check and make sure that their prescriptions, their preferred providers are covered by the plans that they're shopping for. We're very grateful to have a stable market here in Virginia where we have 10 health carriers and 7 standalone dental carriers providing services through the marketplace. As part of that online marketplace and shopping experience, we determine consumers' eligibility, not just eligibility for those health and dental plans, but also for financial assistance programs. The biggest one is the federal premium tax credit program, which I'll talk more about here shortly. But also we determine eligibility for Medicaid so that we can provide a one-door shopping experience for consumers. And when we determine someone eligible for Medicaid, we are able to transfer them directly to DMAS where they can begin the enrollment process for those consumers. As I mentioned, we also provide customer service in the form of a customer service center that has live telephone service, chat, email, as well as Navigator programs. We've worked with our agent community to build a robust network of agents here in Virginia that also perform an important part of outreach and customer service for Virginians. So when we talk about the marketplace, it's important to get a picture of who are we serving here in Virginia. As you look at the coverage landscape in Virginia, roughly half of Virginians receive their health insurance through their employers. Around 17% are Medicare eligible, 15% through Medicaid, a small percentage in sort of other programs like TRICARE. What you see there is the non-group. That's our current enrollment population. We refer to it as the individual population. Individual in the sense that these are Virginians who are not part of a group health plan. Individuals, families, small businesses all fall into this category. Our target population is that slice of the pie labeled as the uninsured in Virginia. Again, one of our core focuses on reducing the number of uninsured and providing health insurance to as many Virginians as possible. I think one of the things I'll say about the individual market or the non-group that I think is important to keep in mind, these are individuals who really don't have any other option for health insurance. They're not eligible for Medicare because of their age. They're not eligible for Medicaid usually because of their income, and they don't have employer-sponsored coverage. There's a small subset that may have employer coverage that's eligible, but that coverage is unaffordable under a federal standard. But for the most part, we're talking about Virginians who have nowhere else to get their health insurance. So let's talk about the financial assistance programs that help to make these commercial insurance products that are sold through the marketplace affordable for Virginians. The really primary resource are these federal premium tax credits. Now, these are tax credits much like every other tax credit that we might be familiar with, both for individuals, for businesses. They are based on income. Eligibility is based on income. They can be claimed at the time an individual or family files their income tax return. But what makes these credits unique is that they can be paid in advance directly to a health insurance carrier to reduce the monthly premium paid by that household. Now, it's a sliding scale. The tax credits are calculated, as I said, based first on income and then as a percentage of health insurance premium to household income. So for instance, and this is a sliding scale that changes based on income, but if you're in the lower tiers of the income brackets, 150% of the federal poverty level to 200%, for instance, right now you shouldn't be paying more than, I think it's 2.2% of your income. And so the credits are allocated to make sure that that premium doesn't cost more than 2.2%. There are a number of other factors. It's a little more complicated, but as a starting point, that's the way to think about those tax credits. Now, prior to 2021, if a household, an individual or household in Virginia earned more than 400% of the federal poverty level, right now that's around $63,000. There were no tax credits available. In 2021, the tax credits were expanded to those individuals over that 400% federal poverty level, and that income contribution percentage was lowered for all of the other income tiers. Those expanded tax credits expired at the end of last year. And that expiration is going to have and is already having an impact on enrollment in Virginia. So when we look at how enrollment in our marketplace has changed from 2021, when those tax credits were extended, it's easy to get a picture of where the impacts are going to be most felt. And so you can see here that we have around 40,000 in both the 138 to 200%, as well as over 400,000 or 400% FPL. And we anticipate with the loss of those expanded tax credits that over 80,000 individuals in Virginia, they're going to be the most vulnerable to this change. And so based on these numbers, as well as a number of other estimates that have been circulating nationwide, We're concerned that by the end of all of this, and I'll explain a little more what I mean by the end of all of this, we may lose up to 100,000 Virginians, or 100,000 Virginians will go without health insurance, nearly 25% of current enrollment. When you look at what this expiration of tax credits looks like in terms of impacts on what people pay in terms of net premiums, you can see how the impact really is across the board regardless of income level, and you can also see where some of the impacts are most dramatic. Now, when we look at that population below 100%, this change is actually not related to the expiration of the expanded tax credits. This impact is a result of H.R. 1. Prior to the enactment of H.R. 1, lawful documented immigrants who were not eligible for Medicaid because of what was called the 5-year bar rule, that is, they had to be in the country for at least 5 years before they could be eligible for Medicaid, they were nonetheless eligible for tax credits through the marketplaces. That eligibility was entirely removed under H.R. 1. And so we have, or had, roughly 19,000 Virginians with an average household income of less than $14,000 a year, whose premiums have gone from about $1 a month to approximately $900 a month. And in the early stages of open enrollment, we already saw around 5,000 of those individuals and households terminate coverage. If we look at what's been going on in terms of our enrollment trends so far during open enrollment, you can see how different that enrollment trend looks this year compared to last year. One of the things that I will acknowledge we did not do a great job of communicating, and unfortunately we've been in good company with the rest of the state marketplaces across the country, was that these impacts to enrollment weren't going to be realized on day one of open enrollment or even necessarily at the end of open enrollment. So what we have so far to open enrollment period is essentially a flat period of enrollment. At points we've had some bumps up that have gotten us to nearly a 3% growth. But you can see how that tail now is starting to turn down much more sharply, whereas this time last year, enrollment was continuing to increase and did all the way through the end of open enrollment, which last year ended around January 22nd or 23rd. So I talked earlier about sort of what this looks like altogether. Some of the things that we're seeing that are indicators of what's still to come in terms of enrollment changes as a result of the expiration of these expanded tax credits. We've seen the number of terminations of coverage double since last year, and that number will be higher today than it was yesterday because it's increasing every day and has been since the beginning of the year. Last year, we added 12,000 individuals after January 1st. And as I said, this year, that it's been exactly the opposite. When you look at it over the course of the entire open enrollment period, we're at about an 85% change in the enrollment rate. As of yesterday, we were a little over 14,000 enrollees fewer, or we had 14,000 individuals fewer, 14,000 fewer individuals enrolled right now than we did this time last year, which represents about 4.5% about a 4.5% change. We expect by the end of open enrollment, which this year for Virginia runs through January 30, we expect we'll be right about the 10% decrease in enrollment. And then it will continue to drop off from there because under federal law, customers who are renewing their coverage, whether on healthcare.gov or through state-based marketplaces, have a 90-day non-payment grace period. And that means that we may not see the full impacts of disenrollments until sometime in April. So, we're doing our best to try to understand behavior of Virginia customers, and this year we've had to go one step further and try to predict that behavior. How many Virginians would see the change in their monthly premium and make decisions right around or right after January 1st versus how many would simply walk away and wait for that coverage to terminate itself. An important piece of this is that for the first 30 days of the non-payment period, health insurance carriers are obligated to continue to pay claims. So for an individual or household who recognize that they can't afford their new premium, really is in many ways in their best interest to wait a month. Now, we're still seeing activity at the federal level. There is, I don't know if I can honestly say hope, but there is still a possibility that the federal government will take action to extend these expanded tax credits in some form or fashion. And one of the reasons that Virginia's open enrollment period ends January 30th this year as opposed to the default of January 15th is we wanted to build as much time for our Virginia consumers to be able to take advantage of those changes. And as we see positive signs of activity, we will consider even further extensions of that open enrollment period to make sure that as many Virginians can get coverage as possible. One of the big things that we really are very concerned about is how difficult it will be to get customers back after they've walked away. We know that a lot of this population, particularly in that 138 to 200% FPL, their contact information changes a little more frequently, making it much more difficult to find and connect those individuals after they've left. We are working to build a number of contingency plans for potential federal action. Those includes contingency plans around our enrollment platform and processes, as well as some robust marketing and outreach campaigns. We have already done some shifts in the way that we're communicating and reaching out to customers to try and build some confidence and make sure that our customers are aware that there are options still available. But it is a difficult time for many Virginians in this space of the market. I really hate to end on that note, but it is the reality of where we are. So I'm happy to take questions.
Kevin, thank you so much. This is, incredibly sobering news. I think the key takeaway for me is there's nothing hypothetical about this. This is not a projection. This is reality, that you're already losing thousands of Virginians who had coverage this time last year who are not renewing, and that is incredibly concerning. We're going to run out of time here, but let's jump right to a few questions, starting with Delegate Gardner.
Thank you, Mr. Chair. Mr. Packett, you may have answered this question for me. I'm just trying to get clarity. When you say to date the cancellation rate, or you said termination rate has doubled, and then you talked about down at the bottom, some of them staying in into the 90-day grace period. Is the termination the individual terminating before, or is it the carrier terminating them, or is it they're waiting until this time period is up, if that makes sense?
It does. So termination and cancellations during this period are consumer-driven. So this time last year, I think we had seen about 16,000 plan cancellations. Sometimes that happens because folks have found other coverage. there's been a change in income, so they're eligible for Medicaid again. For whatever reason, we're well over 30,000 right now. And whether, how many of those are people who have explored other options versus how many are making the determination that it's just not affordable, we don't know yet. There are a couple of other indicators that we're looking at. One is what we call the effectuation rate. That's when people make their first monthly premium payment. That effectuation rate is down almost 6% compared to this time last year. We're also working with our carriers and have asked them to share if they see early changes in trends in terms of late payments, to share those trend changes with us so we can use that as an indicator of what else might be coming sooner rather than later.
Thank you.
Delegate Hodges.
Thank you, Mr. Chairman, and good morning. Welcome. Appreciate you being here. When we talk about, the premiums, they're just skyrocketing. And when we typically look at premiums, people typically think of, all right, age, tobacco use, geographic location, and so forth. But in establishing those premiums, which are done by, of course, the plans, carriers, and so forth, what transparency is in there to justify those costs? How is that reported, and do we have any way of looking at that?
Yeah, that's a great question, and one that the Bureau of Insurance is probably better suited to answer. I know that they did post their rate presentation this year that identified some of those factors, but unfortunately I don't have those off the top of my head.
Okay. Thank you. Delegate Price.
Thank you. Usually the state level will step up for where the federal level has made impacts. Knowing that it would be impossible to fill, I'm still interested in the number. Is there a way for us to estimate how much it would cost for the people that may be left uninsured because of the pie chart that they're on, and uninsured because they got priced out because of the expiration of the tax credits?
Yes, with some caveats. So we've been working to analyze as much of this data as we can, and so I'll give you a couple of pieces of information. If we look at the enrollment as of kind of the middle of our open enrollment period, which was around 360,000. If we look at those 360,000 individuals, we can calculate the portion of federal income tax credits that are helping to reduce those premiums that are tied to this expiration that happened in December 31st. That's around $260 million a year. When we add in the HR1 piece for the population under 100% of the federal poverty level, it's an additional $120 million. Now, how that we've broken that down as by income category as well to get a sense of what is the cost based on potential targeting of individuals and households that are most impacted. So we have a lot of that data, but that data it's point in time data, and what that will look like in the future will require a more complicated actuarial analysis that we have not done. Does that answer your question?
Yes. For the additional information for the, I guess, the data and analysis that you have not done, what would be a potential time frame for you or someone else to do that calculation or analysis?
We're trying to find that out right now from those who can do it, and so I don't have a timeline, but we would, as necessary, we'd work to make that happen as quickly as possible.
Mr. Chair, can I ask that you report to the chair once you know what that timeline could be?
Certainly.
Thank you.
Thank you. Delegate Cornett.
Thank you, Mr. Chair, and thank you for the presentation. The chart that you had with the breakdown of coverage there for all the health coverage for all Virginians, do you have that information that is either district or county specific that you could get to us, or is there a way we could access that?
What we do have by district, we can certainly share the number of Virginians who enrolled in marketplace coverage by district. I don't have that for the other, Medicare, Medicaid employer, but we certainly have it for marketplace coverage, and be happy to share that.
Okay, thank you. The reason I ask is my district has a large Medicaid population, and I'd be very interested to see that information. If there's anywhere you could point me in that direction. Okay. Thank you.
And Delegate Cohen.
Thank you, Mr. Chair. Do you all collect the data on the reason for termination?
We do. So it's, it was built into the system architecture. Unfortunately, it's too expensive. Is not one of the categories that we had built to track, but and I can't remember. There are like 18 different reasons, and so we're trying to sort through that and figure out if there are ways to get at what I think you're talking about, but we haven't resolved it yet.
Okay, I do think that data would be helpful if there's any way to make that magic happen. Thank you.
That's good. Any other questions from the committee here? Yes, Chairman Sickles.
Yeah, Kevin, thanks for all your good work. Could you tell us, would it be helpful to the population we're trying to serve, especially at the lower end, to increase our target in reinsurance from 15% target to some higher target?
So there are definitely positive impacts from the reinsurance program and from increasing that target. One of the things to keep in mind is the individuals and households who benefit from increasing the reinsurance rate are those who are either completely unsubsidized or those who are only partially subsidized, which really is, it's not exactly, but it's around 300% of the federal poverty level and above. Those below, they don't see the benefit because their tax credits are really at a level that shields them from recognizing those impacts, if that makes sense.
I think so. Thank you, Mr. Chairman.
Thank you. Kevin, thank you again for being with us this morning. We've short notice, but super important data. And I know we'll be talking here, talking appropriations, talking across the board, trying to see what we can do. And yes, obviously all our fingers are crossed that we get some help from Washington, but obviously we can't count on that. So we have to take care of ourselves. But I really appreciate you being here this morning. Thank you.
My pleasure. Thank you.
We are going to adjourn shortly. We had a couple of additional members join us, and I know we still have Delegate Shen with us. So, Delegate Shen, if you don't mind, just introducing yourself. We were asking all the members to share one healthy habit that you recommend for everybody. So I'll put you on the spot if you are so inclined to share that. Thank you.
Thank you, Mr. Chairman. I'm very glad to be back in this committee and to work alongside you in your new role, Mr. Chair. I'm Irene Shin. I represent the 8th District, which is Fairfax County, the town of Herndon, Chantilly, and parts of Fair Oaks. This is my third session in this committee and my 5th session total, which is hard to believe. And my healthy tip for folks would be to call your mother. That is good for when I call my mom, it's good for my mental health, but also make sure that I do like a little check-in with her, and that's good for me. So I would encourage y'all to do that too.
Yeah. That may be my favorite healthy tip of the whole thing, of the whole meeting. So no, thank you for that. Delegate Henson was here, had to leave, as well as Delegate Hope, but you'll see both of them. Of course, in action in the future. As I mentioned, we will get those subcommittee assignments made quickly, get the meeting schedule published, and we will go right to that good order. We will have a lot of bills to consider this year. Thank you for your time, and with that, we are adjourned.